Hi guys, good afternoon. I mean, say good evening, good evening. So we are doing a little bit on an earlier scale today. तो आज का जो session है, we are going to take it from 6 to 7. So last session I think we took a gist, which is just an introduction to the tumor status. Go into more elaborate discussion today. So we're talking about the gastric cancers, that is in detailed component of that. Chalo. So when we talk about the CA stomach, first of all, what is the most common type that you can see? The most common subtype that you will see of the gastric carcinomas are going to be adenocarcinoma. No point for guessing, they have glandular tube cells. So when the glandular cells basically provide into malignancy or they convert into malignancy, they're going to develop into adenocarcinoma. Now the small debate or is a controversy is where is the most common site? So you say this is the esophagus, this is in continuation with the stomach, and this is going to be the duodenum. This is going to be the duodenum here. This is the gastroesophageal, right? Now, if you talk about the overall most common site, so I have to convert this into two questions. One, what is the most common site in the Western countries or the Western world? Now, Western countries have the higher incidence of the esophageal cancer or the GE junction malignancies. So, what here the probable answer would be the proximal stomach. It is going to be the proximal stomach. Is going to be at this particular region. This is the proximal stomach, going to be the most common site in the Western countries, right? If I change the question and ask you, what is the most common site in the Asian population? In the Asian population, the answer is going to be distal stomach. The answer is going to be distal stomach, which is going to be at this particular, that is at the pyloric antrum. The distal stomach is going to be the pyloric antrum. Now the question is, which country in the world has the maximum incidence of the carcinoma stomach? Remember, the country which has got the maximum incidence, it is going to be Japan. Now you tell me that Japan is an Asian country or a Western country. No doubt for guessing it is Asian. So if I ask you overall most common site, overall most common site for the gastric cancer will be your distal. The overall most common site, it is going to be your distal stomach, right? So here's the thing that you need to understand. The most common type is going to be the adenocarcinoma. The most common site in the Western countries is the proximal stomach, whereas in the Asian population it is distal. The overall most common incidence, or the maximum incidence of the gastric carcinomas are seen in the distal part of the stomach, and in the Japan, sorry, which country if I say. And the overall, if you consider as one answer, the most common site is going to be the distal part of the stomach, that is going to be a pyloric antrum, right? Now, who are the people who are usually gonna get affected? We're going to talk about the risk factors which are going to drive this, right? So talk about the risk factors associated with gastric carcinoma, right? Now, what are the various risk factors that can be associated, or I can say can be or attributed to the gastric cancers? I can divide the risk factors into three subclasses. One, which is based upon the nutrition. So this is the nutritional cause. Second, it is going to be the environment. It is the environmental cause. We have the nutrition, we have the environment, we have the medical causes. Then I would say other miscellaneous. We have the other miscellaneous. So nutrition, environmental, medical, as well as miscellaneous. Now, in the nutrition, what is important? Under the nutritional risk factors, one of the most important is low fat or low protein diet. Low fat or the low protein diet, right? People who consume salted meats. People who consume salted meat or high nitrate rich diet. High nitrate consumptions, obesity, and usage of complex or increased consumption of complex carbohydrate. So you have the decreased fat or the decreased proteins. Yes, salted means high nitrate consumption. Smoked food can also be in the same context of the nitrate consumption, that you have complex carbohydrates as well as obesity. Environmental risk factors. What are the environmental? Anything that causes increase in risk for H. pylori, that is poor food preparation, poor food preparation, lack of refrigerator, lack of a refrigerator, poor drinking water, poor drinking water, along with that, smoking and alcohol. Right now, all these actually promote the risk for H. pylori. So, in the hindsight, just remember, in the environmental, I am worried about anything that is going to promote the H. pylori organism, because H. pylori is now considered to be class A carcinogen. Now, in the medical component, if I say what are the medical risk factor? In the medical risk factor, all your prior gastric surgeries, prior gastric surgeries, association with H. pylori and Epstein-Barr virus. Epstein-Barr virus. So two infective causes. Then you have any history of radiation, prior history of radiation exposure, atrophic gastritis. Santosh sir will tell you more detail about atrophic gastritis, where he'll be talking about type A gastritis, type B gastritis. Just go watch his videos, they're amazing. You have prior gastric surgeries, H. pylori infestation, Epstein-Barr virus, history of radiation exposure, atrophic gastritis, and presence of adenomatous polyp. Presence of adenomatous polyp. Okay. In the miscellaneous one, in the miscellaneous risk factor, number one, being a male itself is going to be a difficult task. So, male sex, एंड इफ यू आर गरीब मेल फिर तो और ज्यादा प्रॉब्लम है, लो सोशो इकोनॉमिक स्टेट, राइट, मेल सेक्स एंड दी लो सोशो इकोनॉमिक स्टेटस. तो अगर आप मोटा मोटा देखोगे कि व्हाट आर द मेजर रिस्क फैक्टर्स फॉर द गैस्ट्रिक कैंसर्स, मैंने इसको 4 पार्ट्स में डिवाइड कर दिया है. एक आपका न्यूट्रिशनल रिस्क फैक्टर है, एनवायरमेंटल, मेडिकल और मिसलेनियस. ठीक है, तो अगर आप ऐसे याद रखोगे, कोई भी अगर मेल पेशेंट है, अगर वो गरीब है और उसके घर में फ्रिज और खाना रखने की जगह नहीं है और ऑलरेडी उसकी पुरानी सर्जरी हो रखी है, और क्योंकि वो लो सोशो इकोनॉमिक स्टेटस से आता है, उसको एच पाइलोरोई और एप्स्टीन बार वायरस का इन्फेक्शन भी हो रखा है, उसके साथ साथ बेचारा क्योंकि पैसे नहीं है तो लो फैट लो प्रोटीन डाइट लेगा, सॉल्टेड मीट खाएगा क्योंकि फ्रेश मीट खरीदने के पैसे नहीं है. ठीक है, ऊपर से ऑब्वियसली नो, इट सो हैपेंस डिप्रेशन आल्सो कॉजेस ओबेसिटी, तो ओबेस भी हो गया है. ठीक है, इफ यू समराइज ऑल द रिस्क फैक्टर्स, दिस इज व्हाट, एक गरीब मर्द, ठीक है, जिसके पास ना खाने के पैसे हैं, ना खाना स्टोर करने के पैसे हैं, और उसका लक भी खराब था जिसकी वजह से उसको प्रीवियस सर्जरीज भी हो रखी हैं, शायद वो मैलिग्नेंसीज की वजह से, जिसकी वजह से उसको रेडिएशन भी लेना पड़े, और ऊपर से क्योंकि पैसे नहीं है, इन्फेक्शंस आर मोर प्रोन टू हैपन इन लो सोशो इकोनॉमिक स्टेटस, तो बेचारा एप्स्टीन बार वायरस और एच पाइलोरी, ये आपका मोटा मोटा रिस्क फैक्टर है फॉर द कार्सिनोमा स्टमक। दैट क्लियर? ठीक है, आई बात समझ में? सो फar सो गुड। कोई सवाल, कोई सवाल, कोई शक? एनीवन? चलिए, नाउ any patient who develop gastric cancer will present to you with the following presenting symptoms. We talk about the clinical features. Okay? Most of them will have a very vague, or even not comprehensive symptoms. But if I have to put it in single perspective, let's try to understand it this way. Okay? Now, the usual age of presentation of gastric cancers is age above 60 years, and it is more common in males when compared to females. I'm talking about sporadic variety. एक डिफरेंशिएशन है जिसके बारे में हम डिटेलली बात करेंगे, लेकिन अभी के लिए याद रखिए कि 16 ईयर 40, एज अबाव 40, एज अबाव 40 years more common in males in compared to female. ठीक है, now again nothing spectacular about it, थोड़ा सा कॉमन सेंस लगाएंगे तो विल गेट द आइडिया कि भाई ये सिम्टम्स बन क्यों रहे। ठीक है, now if you take this as the representation of the esophagus and this happens to be stomach, I can talk about two set of tumors or two sites where the tumors would actually arise from. So this is going to be the gastroesophageal junction. From here you will see the stomach, the rugosities in the stomach we are going to be present until the duodenum, and the duodenal mucosa will actually. So this is the normal orientation of the stomach that you're going to have. As I told you, there are two possible sites. एक आपका proximal stomach है, which were decided. Another one is going to be distal. ठीक है. Now, as you can see, let it be a proximal stomach malignancy or distal stomach malignancy, they have to either block the inlet or block the outlet. तभी symptoms, ठीक है, क्योंकि स्टमक का ल्यूमेन इतना बड़ा है कि अगर ट्यूमर जब बनना भी शुरू होता है, when it starts even developing, it does not initially cause any symptoms. ठीक है, it has to become large enough to cause substantial symptoms, or I can say the one which are going to present you clinically, उसके लिए टाइम लगेगा। तो इनिशियली जब ट्यूमर बनना शुरू होता है तो वो अपनी अपनी जगह पे बनता है, तो इतने सिम्टम्स नहीं करता, इसलिए इसको साइलेंट ट्यूमर भी बोलते हैं। ठीक है, बट इफ यू से अगर वो सिम्टोमेटिक होने लगा तो किस हिसाब से सिम्टम्स आपको देखने को मिलेंगे, दैट इज व्हाट आवर गेम इज टू अंडरस्टैंड हियर। So I can divide the whole clinical scenario. I can divide the whole clinical scenario into the proximal gastric cancer and the distal one. In the proximal gastric cancer and the distal gastric cancer, we'll try to understand that what will be the differentiating symptoms between these two classes. Okay. Now, all right. Sorry, I'll keep it in English. Don't worry. Okay. Now, as I was saying, I can divide them into two categories. Either it could be a proximal GI or gastric cancer. So we'll take this as the proximal gastric cancer. This is the proximal gastric cancer, and this happens to be your distal gastric cancer. Okay. So you can see the two ends. So as I was saying, either of these tumors, when they start developing in the stomach is a very wide lumen. So it is not very easy for it to block it or to obliterate it to develop symptoms. In order to develop substantial symptoms, the tumor has to grow. It has to either block the inlet or the outlet. Then only the patient will become severely symptomatic. Until then, what are the symptoms that we are going to see? Now, in a proximal gastric cancer, the symptoms that you're going to see is initially, because it is going to block the inlet or start blocking, it will have dyspepsia. Along with dyspepsia, patient can experience dysphagia as well. There will be dyspepsia as well as dysphagia because obviously the inlet is getting blocked. Whereas the outlet, when it gets blocked, it is going to present to you as gastric outlet obstruction. It can present to you as the gastric outlet obstruction. So when we talk about it is going to present to you as a gastric outlet obstruction, any gastric outlet obstruction patient will have repeated episodes of vomiting. There'll be repeated episodes of non-bilious. There'll be repeated episodes of non-bilious vomiting. This will be a projectile vom. This will be a projectile vomiting that the patient will present to you. Okay. So for a proximal GI malignancy, it will be dyspepsia, dysphagia. For a distal malignancy, it is going to present to you with gastric outlet obstruction. Okay. So these are going to be site specific. These are going to be site specific. What are the common symptoms that you can have? Now, the common symptoms, because it's a malignant tumor, it will be vascular, and all vascular tumors tend to bleed more. So they will present to you with upper GI bleed. We have already discussed whenever there's an upper GI bleed, the blood is going to come out from the mouth as well as goes into the stools. Now, as it comes out from the mouth, it is going to present to you with hematemesis. It is going to be hematemesis. Then it would be, and because of blood loss, it is also going to be associated with. So there is hematemesis, there is melena, is hematemesis, as well as right. So these are the three findings that you will have with respect to an upper GI bleed. Apart from that, as the tumor infiltrates into the wall of the stomach, now the infiltration into the wall of the stomach is now going to cause some amount of referred discomfort and pain. Starts in the epigastric region. This can convert into an epigastric discomfort. Now, because it is also going to present to you a dynamic obstruction, which is blocking the gastric outlet, this can also present to you with epigastric colicky. This can also present to you with epigastric colicky pain. So it has got upper GI bleed. It is going to have epigastric discomfort as well as it is going to be associated with epigastric colicky pain. This will also have classical 3As of the malignancy. What are the classical 3A of any malignancy? Because of blood loss, it is be associated with chronic anemia. There will be asthenia. It will be associated with anorexia. It will be associated with anorexia. So there is anemia, there is asthenia, as well as there is anorexia. There is anorexia. Okay. So these are the common symptoms that you're going to present to you. Obviously, one thing that I cannot ignore is going to be significant weight loss. This is going to be associated with significant weight, right? This is associated with significant weight loss. Now, these are the GI symptoms. Everybody knows it. What is interesting to know the extra GI manifestation. We'll talk about what are the extra GI manifestations. What are the extra GI that we are going to have in these patients? I'll start from the head to toe and we'll try to give you in a graphical representation so that you understand better, right? Now, imagine if this is the patient talking about, this is the head, this is, this happens to be trunk, this happens to be groin, this happens to be upper limb, right? Now, this is your upper limb. This guy is saying, hey, what's up? Make it a little bit fancy. He's putting one hand on it, right? This is basically our Superman. So, what are the extra intestinal manifestations that you can have? So, there could be multiple enlarged lymph nodes. Our Superman is going to tell you. So, this is our Superman. Okay. He'll tell you that what are the extra GI manifestations that you're going to have for the carcinoma stomach, right? Just for the sake of understanding, this is where you have the clavicle going to be present. Okay. Now, One second. Okay. So you have multiple enlarged. Okay. So just for the sake of understanding, this happens to be the right side. This happens to be the left side. One second. Right. So what are the findings that you have? There will be one lymph node which is enlarged here. There's one lymph node which could be enlarged here. There are multiple lymph nodes which are going to be enlarged here. And there could be multiple lymph nodes which are going to be enlarged here also. Okay. So these are the nodal enlargement that you're going to have. Now, what are these nodal enlargement? This is your enlarged. This is your enlarged left supraclavicular lymph node. It is your enlarged left supraclavicular lymph nodes. It is also called as the Virchow lymph. They're also called as your Virchow's lymph node, right? This enlarged Virchow lymph node is what we call it as. What do you call it as? This is what we call it as the your. Okay. This is what we call as the Trozier sign. Then you have enlarged left axillary group of lymph. Then you have the enlarged left axillary group of lymph. This enlarged left axillary group of lymph nodes is also referred to as the Irish group of lymph. Also referred to as the Irish of lymph. Then you have enlarged periumbilical group of lymph. Then you have the enlarged periumbilical. It is your enlarged periumbilical group of lymph. This enlarged periumbilical group of lymph, what we call it as the sister Mary Joseph. This is what we call it as the sister Mary Joseph group of lymph nodes. So you have the left supraclavicular enlarged, which is called as your Virchow group of lymph node, the Trozier sign. Then your enlarged left axillary, that is going to be Irish group of lymph nodes. Then you have the enlarged periumbilical group of lymph nodes, are called as the sister Mary Joseph group of lymph nodes. And then if there is an enlarged pelvic deposits, if it is going to go into the pelvic deposit, and this is what we call it as the Blummer shelf. This is what we call it as your Blummer shelf. Now, the Blummer shelf is basically pelvic metastasis. It is your pelvic metastasis, also called as the pelvic secondaries. If you think this is done, no. If I make this Superman into Superwoman, because nowadays it's all about women, so imagine that this is our Superwoman. In like a pony, get her a better pony. So this is the Superwoman that you have. Right now, obviously, women means what? Ovaries. So there are two ovaries which are present here. Now imagine if the tumor falls onto the ovary and it is going to germinate, right? There is drop metastasis onto the ovaries, and this ovarian tumor that is going to develop from the GI component is what we call it as the Krukenberg. So when the tumor pierces the wall of the stomach, it erodes the serosa. After it erodes the serosa, there's a drop metastasis onto the ovaries, and this is what we call it as the Krukenberg's tumor. It is still not done. When you look at the palm, you will see a specific pattern in the palm, right? Now, this specific pattern in the palm, there's a specific pattern in the palm. तो है तो थोड़ा आइसोलेट कर लेते हैं ताकि तो हाँ, तो क्या करते हैं? Right. So, hi, good evening. So these are the extra GI manifestations that you are able to see. The extra GI manifest. You have the enlarged left supraclavicular group of lymph. Enlarged left supraclavicular group of lymph nodes is a virtual group of lymph nodes, which is a Trozier sign. Left axillary, Irish, periumbilical is going to be Sister Mary Joseph. Drop metastasis into pelvis is Blummer shelf, and drop metastasis into the ovaries are what we call as Krukenberg tumors. This Blummer shelf you can only appreciate by doing a digital rectal examination. So this Blummer shelf, this can be seen in digital rectal examination. This can be felt in a digital rectal examination. So when you look at the palm, you will see a specific pattern in the palm. You will see the palm will have become all these scaled ones. They're very extensive scale. Palm is going to become like this. Just for the sake of understanding, palm, the palm is going to become like this. This is what we call it as the tripe palm sign. This is what we call it as the tripe palm. So what is this tripe palm? It is your hyperkeratotic palm. This is your hyperkeratotic. This is your hyperkeratotic palm, right? On the other hand, when you look at on the back, that is on the torso, you will see multiple skin lesions which are present. All the skin lesions that you're seeing on the torso or on the back. This is what we call it as the lesser Trellat sign. This is what we call it as the lesser Trellat. So what is this lesser Trellat sign? It is your multiple seborrheic keratosis. It is your multiple seborrheic keratosis. It is your multiple seborrheic keratosis. So these are your extra GI manifestations of your carcinoma stomach. Is that clear, guys? Okay. So this one diagram basically tells you all the manifestations that can be present apart from the GI manifestations of the carcinoma stomach, and this is what we call it as the extra GI manifestations of the CA stomach. So far so good, guys. कोई सवाल, कोई shock, any question? Can we move on? Sure. So this is about your extra GI manifestation. How would you like to investigate? In terms of investigation, the patient either presents to you with dysphagia like presentation, or they're going to present to you either they're going to present to you as dysphagia like presentation, or they will simply present to you with your gastric outlet obstruction like presentation. Either ways, logically, the first investigation would be your upper GI endoscopy. Now, when you do an endoscopy, either you will see an ulcerated mass or an polyploidal or an elevated mass. So this either an ulcer or there will be a lesion that is present. In order to conclude that, I would like to perform a endoscopic biopsy, and this becomes the investigation. This becomes the investigation of. What are the other investigations that you will do? You will do an endoscopic ultrasound to look for the T staging or the invasion of the tumor. Okay. Apart from that, you will also do the CCT of the abdomen. Now, the CCT of the abdomen is to look for loco-regional spread, right? I will also perform the PET-CT to look for distant metastasis. PET-CT to look for distant metastasis. To look for distant metastasis. I'll do an upper GI endoscopy with biopsy as the investigation of choice. I'll do an EUS for T staging. I'll do a CCT abdomen for evaluating the loco-regional stage. It is to assess the loco-regional spread. For the assessment of the loco-regional spread and PET-CT for distant metastasis. PET-CT for a distant metastasis, right? Now, once you've done the biopsy, we have a classification to know what kind of a context or the type that you're looking at, right? On the basis of HP, we have a classification that is what we call it as the Lauren classification. We have a classification called as the Lauren classification, right? It's a HP classification. So, when you talk about the Lauren classification, I can divide them into two varieties. Number one is your intestinal type. And number two, it is going to be your either you call it as the intestinal type or you call it as diffuse type. The two subsets that you have, right? Now, on what basis are we going to divide this? Let's quickly have the components on which we are going to evaluate them, right? There will be various components on which we'll be evaluating them. We look on the following components, which is more likely to be involved, that is sex, age of presentation. I look for the genetics, that is both genetic, the mode of inheritance, or I can say the pattern of inheritance. So the pattern, then we'll talk about the genetics. We'll talk about any associated risk factor, the mode of spread, on histopathology, what is the likely diagnosis, and the predictive prognosis. So this is what we are going to look into it. We'll categorize them on the basis of the following components. See, what is the most likely called sex, the age of presentation. Then look at the pattern, genes which are usually getting involved, the risk factor, mode of spread, so pathological diagnosis, and the prognosis. And the prognosis. Right? Okay. So let's look at the comparative. Uh, okay. So according to the Lauren classification, now the intestinal variety is more commonly seen in males when compared to females. Diffuse variety is more common in females when compared to males. The usual age of presentation is age above 50 years. Is age above 50 years. But remember, the risk factor continues to increase as the age of the patient continues, right? The risk increases with increase in the age of the patient. whereas here it is relatively seen in younger patients. So the usual age of presentation here is going to be between 30 to 40 years. It is going to 30 to 40 years. When I say pattern, remember this is sporadic. That means it can be seen in any person as a general population. This is your familial component. This happens to be your familial component. Now the genes which are usually involved is your APC gene mutation here. But the other two which are common is going to be P53 and P60. The other one is going to be the E-cadherin gene mutation. It is the E-cadherin gene mutation, again associated P53, and again it will be associated with the P53 and the P60 mutation. When I say risk factors, it is associated with gastric atrophy. It is associated gastric atrophy and intestinal type of metaplasia. Call it as the intestinal meta. It is the intestinal type of metaplasia. Here it is associated with blood group A. Here it is associated with blood group. The mode of spread for your intestinal variety is going to be hematogenous, that is blood, whereas diffuse variety is going to be direct or via lymphatics. It is direct or via lymphatics. The HP for this is going to be gland forming. This is going to be the gland forming, whereas here it is going to be the signet ring variety. It is going to be the signet ring variety. The prognosis here is going to be good, whereas the prognosis here is going to be. So this is the Lauren classification. In fact, it is a very, very famous classification to differentiate between the intestinal variety and the diffuse. To differentiate between the intestinal variety as well as the diffuse variety. Based on the upper GI endoscopy only, there's another classification that you have, which is on the morphology, right? So upper GI endoscopy, based upon the upper GI endoscopy, we have a classification that is based upon the morphology. The morphological classification. Now this morphological classification, it is divided into two varieties, one for the early gastric cancers, another one for the advanced gastric cancer. One is for the early gastric cancers. Another one is your advanced gastric. Another one is going to be your advanced gastric cancer. Hi, Sade, good evening. Now, based upon the morphology, अगर आप endoscopy करोगे, when you do endoscopy, you will have two subsets. One is early, another one is your advanced gastric cancer. Purely on the basis of morphology, how would you look at it? Now, imagine that this is a block of the tissue that you are evaluating. Based upon how it looks, we have the different types. Now, if this is one block of tissue and you see the tumor is going to protrude like this, right? This is type 1 variety. Then you have a block of tissue which is present here. This block of tissue has a tumor, but it is going to be like this. This is your type 2A variety. Then you will have, this is the block of tissue that you are examining. Let's say on an endoscope, you see a tumor that is present, but it is at the same level as the mucus. This is another variety. Obviously, logically, what are going to happen? This is now going to become a little bit depressed. This is a tumor is here, slightly depressed, right? Then you see it's a depressed one, but this time the tumor appears to be aggressive. It is going to have a local, it is digging deep, called as X curve. So based upon the morphology. These are the various varieties you have. This is your type 1 variety. This is your 2A variety. This is your 2B variety. This is your 2C variety. This is your type. Now, what is your type 1? It is what we call it as the protruded type. This is your protruded variety. This is flat and elevated. This is flat and elevated. That is superficial elevated. 2B is going to be just flat. 2C is going to be depressed. And 3, it is causing local infiltration. So it is called as excavated. This is what we call it as excavated. So there is protruded variety, flat and elevated, just flat, depressed, and the excavated variety. These are in the form of the early gastric cancers. Same thing when you look at an advanced gastric cancers, same block of tissue. One second. Right. So in an advanced gastric cancer, you have one where you have this type of growth pattern. Then you have ulcerated lesion present here. Now this ulcerated lesion is slightly interesting because you will have the ulcerated, then elevated, then elevated. This is your another variety. Then in the type 3 variety, we'll see with an infiltrative margins. A tumor which is going to be like this through and through. And the last one will be non-classified. So this is what we call it as the type 1 variety. This is your type 2 variety. This is your type 3 variety. This is your type 4. And then you have type 5, which is non-classified. Will be a non-classifiable. Now, what is type 1 variety here? The type 1 variety here is polyploidal. Is your polyploidal. Type 2 variety is ulcerated with elevated margin. Type 3, it is going to be ulceration with local infiltration. There is ulceration with local infiltration. And one that involves the entire circumference and the thickness, it is what we call it as the linitis plastica. It is your linitis. In fact, linitis plastica is the one which is associated with worst. Now, if a lesion does not qualify in any of the above, it will become type 5, which is considered to be as non-classifiable, which will be considered as a non-classifiable. Okay. So this is based upon the upper GI endoscopy and on the basis of early gastric cancer and the advanced gastric cancer. Now, before we start up with the core management, you also should know the lymphatic stations which are associated with the stomach, right? So I'll quickly go with the lymphatic stations of the stomach. Talk about the lymph node state. And then I'll describe you what is a D1 station basically means, or what is a D1 level basically, what is a D2 level. There's a lot of controversy behind it. We'll try to address it, right? So here, don't worry. Now take this as a representation of the esophagus and this as a representation of the stomach, right? So there are various subsets of the lymphatics which we'll have to understand and go accordingly, right? Now in the first subset of the lymphatics, one that is going to be present around the cardia of the stomach. One is going to be right paracardial, another one is going to be a left paracardial, right? Then you have one that is present on the lesser curvature of the stomach. Another one is going to be on the greater curvature of the stomach, right? Now, in the greater curvature, one that is going to be following the short gastric arteries, that is one subset. Another one which is going to be following the right gastroepiploic artery. We remember short gastric artery, both of them are basically the branches of splenic artery. This is one subset, right? Then you have one which is above the pylorus, suprapyloric, and one which is going to be below the pylorus, which is going to be infrapyloric, right? This is what we call it as D1 level, right? So what is a D1 level? What is a D1 level of gastric lymphatics? In the D1 level of gastric lymphatics, all these are specifically numbered. This is station 1, this is station 2, this is station 3, this is 4S, and this is 4S, right? That is 4 station A, 4 station B. That's it, right? This is your 5 and this is your 6, right? Now, I've given, see, all these are around the stomach, nothing spectacular about it. If I have to label them, the station 1 is going to be your right paracardiac. It is a right paracardiac. Station 2, it is going to be left paracardiac. Station 2 is going to be left paracardiac. Station 3, it is going to be on the lesser curvature. Station 4 has station 4A and station 4B. 4A is along the short gastric arteries. On the short gastric artery. Another one, it is going to be with respect to right gastroepiploic artery. It is our right gastroepiploic artery. Station 5 is suprapyloric, and station 6, it is going to be your infrapyloric. Station 6 is going to be your infrapyloric. Okay? So these are these lymph nodes, their stations and their number. Is everybody clear with this? A quick feedback. These are very, very typical and important concepts. Are you guys clear with this? Quick feedback. Quick feedback. Quick feedback. Can you move on? Can you move on? So this is about your D1 level. Something is not sticking right. Okay. So in few textbooks, station 7 is also given as D1 level, that is along the left gastric artery, but we'll try to put it across in the same context. Okay. So this is about your first level of lymphatics. Now let's go here. Again, esophagus. This happens to be stomach, the duodenum that you have, right? Now, usually when you talk about the blood vessels, which are important here, this is going to be the celiac artery that you have. This is going to be your left gastric artery, which is your left gastric artery. This happens to be your splenic artery, which is going to go behind this, the splenic artery. This happens to be your hepatic artery, and this hepatic artery will give rise to two important components. One, obviously, it is going to give rise to the gastroduodenal artery, but this is your common hepatic artery. That was hepatic artery proper. This was your gastroduodenal artery, which is going here. It's going to be a right gastric artery, which we already discussed it. Now, obviously, this will go behind, convert into the anterior and the posterior superior. From here, from here, it is continuing to form into the left gastroepiploic artery, which is here. This is going to convert into right gastroepiploic artery. This will develop into short gastric artery from here on. Splenic artery. Nothing spectacular about it. I'm just quickly labeling them also. This happens to be your celiac artery. This is your left gastric artery. This happens to be your splenic artery. This is your right gastric artery. This is your gastroduodenal artery. This is your hepatic artery proper, and this is your common hepatic artery. This is your common hepatic artery, which is here, right? So when you look at station 7, where do you have station 7? The station 7 is at the left gastric artery. This is at your station 7. 8A is going to be at the common hepatic artery. It is going to be 8 is going to be along the hepatic artery. 9 is along the celiac artery. 10 is going to be at the splenic hilum. 11 is going to be at the spleen per se. When we talk about 11, is going to be at the splenic artery. 11 is going to be along the splenic artery, right? So these are your station are going to be. So I just simply label them. This is going to be your station 7. Then you have the station iliac artery is 9. Splenic hilum is 10. The splenic artery is going to be 11. Okay. So look at the stations. Station number 7, which is going to be along the left gastric artery. Along the left gastric artery. Station 8 is along the hepatic artery. Station 9 is going to be along the celiac artery. Along the celiac artery. 10 is at the splenic hilum. And 11 is along the splenic artery. It is along the splenic artery, right? So this is your D2 level. So you have the D1 level. Sometimes D1 level is 1 to 6 in two textbooks, it is 1 to 7. We will consider 1 to 6 here, and D2 level. D2 will be all the way. It is going to be D1 plus all this. Okay. So station 1 to station level is called as D2. Station 1 to station 6 will be called as D1 level. It will be called as D1 level. Okay. So this is your D1 level as well as D2 level. Now, the other one that is going to be present. This is going to be with respect to the following one. We'll talk about the D3 level. So when you look at the D3 level, esophagus, stomach, duodenum. I said 12 is going to be hepatoduodenal. That is the junction that you have at the hepatoduodenal. That is going to be a 12 one. If you take this as a representation of the cardiac artery, from here you have hepatic artery proper, you have the right gastric artery, which it continues to form the gastroduodenal artery. This is your common hepatic artery, right? Following this will be your station number 12. ये जो है आपका, ये आपका station number 12 हो गया. Then you have the pancreas which are present here. You have the pancreas which are present here. Behind the pancreas, the lymph node that you have, which is going to be here. The it is of the pancreas which is present here. Behind the pancreas which is present, it is your station number 30. So retropancreatic is your station number 30. Now you will see that there are veins which are going to be present here. All these veins will combine together to form one particular one. यहाँ पे इसी context में hilum में you have the superior mesenteric vein which is present here, right? You have the splenic vein which is going to come across here, and together they are going to form the portal vein here. तो portal vein का जो status है will be like this. This will be in combination with the splenic vein. There will be inferior mesenteric vein that comes from here, and together with respect to this your superior mesenteric vein, right? Obviously, next to it, your superior mesenteric artery is also there. Now, one that is present along the superior mesenteric vein and the superior mesenteric artery. You will see the superior mesenteric artery will both it is going to be in that hunch of the pancreas only. This is your superior mesenteric artery. This is one node station, this is another node station. If I have to label this off, one that is present with the vein is going to be 14V, that is vein, and this is your 14A, that is going to be artery. 14 vein and the 14 artery. Then you have the 15 one. As the superior mesenteric vein will be combination of multiple veins together. Now it is going to be middle colic. I'll just label them rest of them because it is difficult to visualize. So if I say what is station number 12, the station number 12 is going to be along the hepatoduodenal artery. It is your hepatoduodenal artery. Station 13, it is going to be retropancreatic. It is going to be retropancreatic. It is going to be retropancreatic. 14A is along the superior mesenteric artery. 14V is around the superior mesenteric vein. When you talk about 15, it is going to be along with the middle colic vessels. It is with the middle colic vessels. Station 16, it is going to be aortic, I will say para-aortic, aortic and all that. So it is going to be around the aorta. Around the aorta, you have the aortic hiatus. Then you have para-aortic middle. We call it as the middle para-aortic. And below, that is caudal para-aortic. So station 12 to 16. Okay. So this is your different levels that you have, right? So D1, D2, D3, and these are the various subsets of lymphatics that are going to be present. See, when you look at once now, it is difficult for you to comprehend. But if you look at these images, look at these hand-drawn images, you will be able to understand one that is around the stomach is D1. Along with its major blood supply is D2. Away from that is going to be D3. Is that clear? Is that clear? Quick feedback. Okay. Right. So that is it for today, guys. Thank you so much for joining. Tomorrow, I mean, the next session that we have, we'll have on the management of the gastric cancer. We talk about the diagnosis, classification, all the pedigree that is required. We have it. So next time when we meet, we'll talk about the TNM classification, staging, stage-wise management, surgery, post-operative complications. That is our next set of lesson. Until then, thank you so much for joining. Take care. Good night. Bye bye.